Akin. I'm a volunteer here in the Leadership and Development Coordinating Team at HFN. So we're an organization that is focused on assisting state governments in achieving basic primary healthcare goals. And we have various programs by which we do that. And one of them is our nurses school program, of which we have some of our lovely nurses here today. So our organization is headed by a founder, Dr. Bim Akintade, who has a strong passion for transformative healthcare change. And yes, we have our some of our team members here. Ruth, who is our operations director, and Nurse Luro, who is the head of our our nurses school program. And also, like I said, I'm part of the leadership and development coordinating team. I also have my team member, Olumide Ode, who is not here today. So today we have the privilege of having Dr. Anthony here in our midst for our training workshop. So Professor Anthony Ndubisi Nwaiwu was born and raised in Imo State, Nigeria. He joined the University of Maryland School of Nursing, Baltimore, Maryland, United States, from MedStar Harbor Hospital, where he was an educator and an administrator for many years. He was an adjunct faculty member at University of Maryland School of Nursing for 2 years before he took a full-time position about 3 years ago. So over the past 23 years, he has worked in different healthcare systems, some of them including healthcare systems in jails, nursing homes, and hospitals. And he has also occupied various leadership positions. So prior to coming to the United States, he graduated from Alvan Ikoku College of Education, also known as in University of Nigeria, Nsukka, with a diploma in physics, and chemistry education. So he completed his NYSC at Isoko in Delta State, Nigeria. Thereafter, he transitioned into teaching chemistry and physics in the senior classes at the Itere Community Secondary School, Lagos State, for about 5 years, where he was also a syndicate with the West African Economic Council, Examination Council, sorry. After migrating to the United States, he received his Bachelor of Science in Nursing in 2001. He also received a master's degree in Health Services, Leadership, and Management Business in 2014. And he also did a postmaster teaching where he got a certificate in nursing and health professions in 2018, all from the University of Maryland School of Nursing, Baltimore, Maryland. He completed his doctoral program at the University of Maryland in 2018, and his scholarly projects focus on quality improvement. So currently, he's the director of 2 programs at the University of Maryland School of Nursing. Over the course of his professional trajectory, he has received several professional awards and made many academic presentations, of which one of them is today. His teaching philosophy is student-focused, and he believes in innovative teaching methods and supporting mutual collaboration between students and faculty. Dr. Anthony's presentation will be on HIV, with a major focus on nursing and medical interventions. So without further ado, I would like to invite our guest speaker, Dr. Anthony, today.
Wow. Thank you for that extensive introduction. My colleagues, professional colleagues, wherever you are all over the world, thank you so much. I have the honor and privilege to be in your midst today for us to share today intellectual ideas. We are all on the same field. Nursing has become the bedrock of healthcare system in United States and beyond. Over 15 years, this profession has been voted as the most trusted profession in United States in 15 years in a row, except in 9/11 that the firefighters took first and we came second. Other than that, we are in an eminent profession. It's no longer a profession before people regarded as messengers to the doctors. Today we share equal resume, share equal intellectual abilities and ideas, And wherever you are, you lift your face so high as thank you to be in your midst. So, sir, if you allow me, you want me to share my slides today?
Yes, sir. You can go
Okay.
ahead. Sir.
Okay.
Thank you, sir.
You're welcome. Okay, so welcome all of you. Today we're gonna make a discussion. I will make it as concise, precisely as possible to drive home the important points that will help all of us in our daily care of our patients and also enrich our knowledge within our environment. So our focus is gonna be nursing care of patients experiencing HIV and S. We will have major objective by the end of today's seminar. The participant, which is all of you, will be able to trace the pathophysiology of HIV. You'll be able to describe and evaluate the signs and clinical signs and symptoms for patients with HIV. And all of you will be able to sit down and design a nursing care plan for patients with HIV or S. And we'll be able to identify and plan laboratory and diagnostic data in conjunction with clinical manifestation to support the diagnosis and the effectiveness of therapy for patients with HIV. And you go ahead, you'll be able today, it's gonna be 1 hour, you'll be able to identify, apply the nursing care priorities and teaching points for patients with alteration in immune response. And we'll be able to equally go and talk about identify special consideration for patients with alterations in the immune system. And without further ado, let me go ahead and talk about HIV and of course S. HIV, as all of you know, is a retrovirus that deter our body's immune system, invade our body immune system by taking over the soldier of the body, which we call the CD4 or T cells. So they come as a stranger antigen, be able to invade and destroy that mechanism that defend our body system from infection. It's present all over the world. United States in 1970s, that's when it came into eminence. But before I go into pathophysiology, I think it's gonna be pertinent for me to give a small demographic data or history of HIV. HIV infection in human came from a type of chimpanzee in Central Africa many years ago. The study showed that HIV may have come from a chimpanzee to human as far as the 18th century ago. The chimpanzee version of that HIV is called the simian immunodeficiency virus. Probably it was passed to man. During those days, men were hunting. And this chimpanzee came from means and encountered when the hunters got infected with the blood from the chimpanzee. It was able to transfer to them. So over the decades, HIV slowly spread across Africa and later into other parts of the world, become a mystery that invaded the whole world. The virus has existed in the United States since the late 1970s, just like I said before in the last slide. But still 39 million people today living with HIV globally. About 68% of these are in sub-Saharan Africa, where most of us come from. 9.2 million people are not accessing HIV treatment because of some factors we will see today. 630,000 people died from AIDS-related illnesses in 2022. So we can see that this is not a sickness that all of us can negate in our daily care. So between 2010 and 2019, there has been a 23% decline in new HIV infection globally. Thank God. The new use of medication, awareness and treatments, intervention have declined, helped to decline it, but still, it's still a problematic situation worldwide. Nigeria, as a case study, Nigeria ranks about 5th among countries with the highest cases of HIV immunodeficiency virus in the world. During the 2020 Nigeria National HIV/AIDS Indicator and Impact Survey found that 1.7 million people are living with HIV and AIDS in Nigeria as of 2020. In 2018, it was about 1.9 million. So there is also a decline shift in the number of people with HIV. Remember, this is a statistic. We still have also undisclosed people that are unable to come up with HIV because of stigma and other cultural barriers, which we will see today. And I rank you the countries. I put the ranking of the countries. South Africa is the leading with 7 million, 7.8 million. With India and Nigeria, we came into a tie with Tanzania, but they still place on that fifth. So let's talk about the pathophysiology of this HIV. The theory is that HIV invade our body system. As all of you know, we have the white blood count. The normal level of white blood count is 4,500 to 11,000. And within the white count, we have the CD4, which is the soldier of the body. So what HIV does is that a small particle, genetic material surrounded by protein shell, came and attached itself with the CD4, white CD4 blood cell of a normal human body. So when it gets attached, it infuses itself into the CD4 of a healthy person, integrate itself with the CD4 and become part of the equation. In so doing, the single HIV single strand become converted to a double strand DNA. This process of replication becomes a continuous process. The essence is to invade and capture the host. You know that the bacteria we call the antigen. The body produces the antibody that attacks that antigen. So it gets suppressing the antibody, the antigen, which is the HIV virus. Converter keep on suppressing the CD4. So this viral copy leaving the CD4, get another one, attach them, get another one, attack them, recuperate them. As they get this integration, the body mechanism, defense mechanism become weakened. So the newly converted HIV DNA enters the nucleus of infected CD4 and become part of C cells of the DNA. This is why people that have CD4 have a very, people that have HIV have a very low CD4 count. The good point I want you to drive home is about two variables. The viral loads, which is the infectious process that happens, and the CD4, which is the counteracting mechanism that attacks them. As the CD4 is suppressed, the viral load increases. Those of us that are species of science will say that the viral load is inversely proportional. So this will fall count. In a healthy person, the CD4 values from 800 to 1,200. So as this CD4 count keeps suppressed by the host, by the invading, HIV, the CD4 count keep declining. When the level of CD4 can decline less than 200, the patient is suffer what is called AIDS. That's when we classify them as AIDS. So you can see that if it is tackled at the primary stage, the patient's life will not be progressed to S. And that it is our duty as nurses, as we go today, to be able to be part of the equation that will be able to present the ideas to the patient and see that medication regimen and other things that we're going to see today will help them to live a healthy life. We will see today that many patients that has HIV live a healthy life if the CD4 count is controlled, if the viral load is controlled. Because when the viral load is less than 50, a patient is not transmissible at that point in time. So how do we test the patients? I will make it so simple. There are major tests. The first one is the antibody. The antibody is that when the antigen, which is the HIV, attacks the body, then the body produces the antibodies that will attack those antigens. So when we're testing, we're trying to test the antibody test, just like when you do the COVID test. So that antibody test is going to be viral copies of HIV, which will be detected by the body during the blood work. We also have the ELISA test, which is the enzyme link immunosorbent assay test. This is a very, very highly sensitive, but it has many false positive results. The confirmatory test for that is what you do, the West blot, which is a confirmatory test to verify the positive ELISA test. And then we have the viral loading test. This viral loading test is always a baseline. Somebody comes to the clinic, you want to test them and see, well, what is your viral load? It presents you the baseline at that point in time. So after the course of treatment, say the viral load was 10,000. After the course of treatment, we want the viral load to keep on what? We want the viral load to keep on decreasing. So you repeat it again after a test to see how the viral load is going. And that's why every time in the hospital, you see people with HIV, probably they come every 3 months or 1 month to test for their viral load, because we are trying to find out whether the medication regimen we are on is very, very effective for the patient. Undetectable viral load, it doesn't mean that it's not an indication for cure. HIV has no cure, but we can suppress the viral load in such a way that the patient will not be infectious. Another test is what we call the antigen antibody. This test seems to be the best test for HIV because we are tracing both the disease process and the antibody. You look for both antigen and antibody. It's done in the lab, it's a blood work. Then we can also do the RNA and DNA test, testing for the actual virus and the copies of RNA. That test is a test we use to confirm the rapid HIV test we do. The rapid HIV, which you do the finger stick prick, or oral quick test, takes about 20 to 30 minutes here in US, and I think over there, it has about 99.6% accuracy. However, this test with time, if you do it, you still have to do RNA DNA test to have that confirmation test. So the basic things to get the test, looking, targeting for viral load and CD4 count. Like I told you before, CD4 count has no normal CD4 count, but we know when it is, we'll say it's high or low. When it's above 10,000, it is high. When it's below 500, it's low for viral load. The target point is to have the viral load less than 50. What are the stages of HIV? The HIV has 3 stages. Number 1 is the acute infection phase. The acute infection phase of HIV is within 2 to 3 weeks of infection. The patient starts complaining of flu-like symptoms. You see, some of them will say, well, I have malaria, I have cold, I have this, because flu-like symptom is a typical symptom. Low fever, sneezing, coughing, those stuff comes up with the patient. At that particular point, the replication of the viral HIV is high. So you have a very high viral count. Now, if it is untreated at that point in time, it goes start moving to clinical latency stage. This is a hidden point. Latency in physics means hidden. This stage is called asymptomatic or chronic stage. That time they're hidden. But at that time, the HIV is still replicating, but at a very low rate. How long a patient will be on this stage depends on medication regimen. Are they compliant with the medication? Are they taking their medication regularly? And if they don't, this stage, this can be in this stage up to about 2 years to 10 years. HIV is staying there in a dormant, latent state. However, for those of you nurses, if some of you usually here, I teach NCLES for the NCLES in the United States, like the clinical latency of HIV, because they want to know what is happening at clinical latency. At the clinical latency of HIV, that is the time the viral load goes high and the CD4 count goes down. Has suppressed the CD4 count. The body is already surrendering at that point in time. And that takes us to the 3rd stage. The 3rd stage, the stage is stage 3. The stage of acquired immune deficiency syndrome. That is the time that is very, very, the immune system is compromised, severely compromised. The body system is done. The patient start having some opportunity infection. If somebody sneezes, they will get it. If somebody coughs, they will get it. Because the body mechanism has fallen apart. The body doesn't have that instrument again to repel, to attack any kind of antigen. It doesn't produce enough antibody to neutralize the fate of antigen that attack it. So the body surrenders. And that is the time, at that point in time, we start having some opportunity incursion, something like pneumocystis, pneumonia, Mycobacterium avium complexes, toxoplasmosis, non-Hodgkin's lymphoma, Kaposa sarcoma, candidiasis, invasive cervical cancer, cytomegalovirus, encephalopathy, and etc., etc. The list goes on and on. Because the body immune system is compromised. The body now is vulnerable to attack. So transmission. This one is a big one because you see, one of the things that kill our people, especially in Nigeria, is that everybody is scared of people that have HIV. The healthcare providers are even scared to touch people with HIV. Is the noise coming from me? No, I don't think so. Okay. The healthcare providers are scared to touch people with HIV. People within their village system or community system is also well, sir, there's a noise coming up. Is it from me?
Yes. Sorry, Rose, can you please mute your mic?
Okay. Thank you so much. Appreciate it. So the transmission is a big one in our talking education to our people. How is HIV transmitted? It doesn't mean you touch somebody with HIV, you get it. HIV is transmitted by 4 or 5 major ways. Number 1, sexual contact. It could be through the anal or vaginal. The semen and secretion is passed from the host to the other person. It's transmitted from the person to the host. Or needle sharing, IV drug user, people that share needles and syringes, or even some chemists at home with print to them. People use needles and use it to another person. That's dangerous because that is an easy way to get all these blood pathogens transmitted from person to another. Blood transfusion is no longer a big deal, especially in the developed world. Before it used to, but it's no longer a big deal because the blood's now refined and goes so many processes. But through blood transfusion, easily one can get, people can get it happen. Mother to child through pregnancy, bad breastfeeding is also, if a mother is HIV and it doesn't take adequate medication, they can transfer it from mother to the child, to the offspring. And I put HIV is passed on through blood, semen, vaginal, anal mucus, and breast milk. If a person with HIV, that is if the person has a detectable viral load. If the viral load is not detectable, they not get transmitted. You don't pass it by spitting, sneezing, or coughing. And the question somebody asked me last month when I was making this presentation is, can HIV be transmitted through oral sex or menstrual fluid? The answer is yes. The probability is low, but it is possible because you can have the mucosa membrane traveling to the mucosa membrane. It's possible. HIV is not transmitted at all through saliva, tears, urine, sputum, sweat, physics, touch, toilet sharing cutlery, kiss, or insect bite. Somebody asked me the other time, what if somebody has a wound in the mouth? I said, well, you're gonna be, I don't think you'll be, if somebody has a blood bleeding in their kiss, no matter the amount of love, you're gonna tell them, honey, keep that love for now. We'll do it next time. So you don't do that. But if somebody is bleeding from the mouth and you're bleeding, you kiss, where the probability is that you get the blood through blood contact will be there. Other than that, normal kissing, HIV is not transmitted through that. Evidence have not shown that at all. What are the clinical manifestations we as nurses and healthcare providers see? Fever is common, cough, They start coughing, weakness. They complain of so much weakness because the body immune system is weakened down. CD4 count is low. The viral load is too high. Patients starting having nausea, vomiting, diarrhea because of triggering of sympathetic nervous system that triggers all those systems start having nausea, vomiting. Shortness of breath, yes, because of respiratory compromise. The patient start having some shortness of breath. Headache, well, build of metabolites in the brain can cause encephalopathy, confusion, as patient can start complaining of headache. And night sweat is a big goal. They can change their linen or bedding every night because they're sweating all over. Lymphadenopathy, yes, the lymph node enlargement and other things comes as a result of decrease in immune system. And other symptoms of decreased immune function can equally happen. If you look at here, see this blister-like and this tongue, these are simple stuff this is like sarcoma. This is thrush that happens here. Those are things that comes with the end stage when somebody has HIV. And I have other diagrams here. The oral thrush, the candida. This is a typical Kaposo sarcoma. See all the blister-like all over the body is there eminent. So I made this important point. I've mentioned them before, but I call it therapeutic modalities. It's something very important. It's kind of a summary synopsis. Patient with less than 500 CD4 cells or a viral load of over 10,000 should be offered treatment. This is a time they should be offered treatment. And all patients with 200 or less CD4 count should be treated because at that point, the patient is likely is going to else. The goals of treatment is to decrease the viral load as much as possible. That's the target. Decrease the viral load as much as possible, boost the CD4 count. The viral load below 500 copies is considered low, and undetectable viral load is when they drop below 50. I've told you that at this point in time, patient is not transmissible. In a healthy person, CD4 value is 8,300 to 1,200. Those are the important points I mentioned before. What are the medical management? Number one, CD4 count and viral load is checked every 3 to 6 months. Go to the doctor's office, you check it and see what they see, because these are the dependent variables. These are what determines how well the patient is doing. If the CD4 count is coming up and the viral load is going down, that's a good regimen. The medication regimen is working. But if there is no effect of that, then it means that the treatment is inconsequential, of no effect, is insignificant, does not produce any realistic change. We can talk about genotype assess, drug-resistant viruses strain, because at that point in time, they can start having some resistance, so a lot of treatment. TB is an opportunity infection. They take that opportunity of compromised immune system to invade the patient. So we take them TB screening every 6 months. Your other test is as symptom emerges, as they have other things on, because they will have start having other symptoms because the immune system is invaded. It's just like when you live in a ghetto place and you're surrounded by enemies, you don't have anybody to protect you. Then you're vulnerable. They can just pick you by just a wave of hand. The dosing of medication, how the doctor decide how the patient will be dosed, what kind of medication they will get, depends on the viral load and CD4 count. That's the dosing of medication. Medical management, I made mentions of some other medications here. We have highly active antiretroviral therapy chart, which is a combination of medication regimen, 2 or 3 medication regimen the patients follow. We also have the nucleoside reverse transcript inhibitors. Adenosine is a good match for that medication too. We have non-nucleoside reverse transcriptase inhibitors. Sostiva, a good medication too. And you're gonna see it when we talk about prophylactic action. So we have different kind of them. I mentioned different kind of medications. What are 3 drugs regimen from at least minimum 2 classes. Nowadays, we have other active medication that have been produced, 1 medication combined together that can take care of this. Just 1 medication a day. 100% adherence for lifetime. Compliance is the key. The compliance of medication regimen is key, because when you start a medication and you stop it, it has a counter effect on the patient. It helps to destroy their own immune system and make them more compromised to the problem. So that's why taking the medication at a regular time when it's supposed to be taken. As all of you know in the clinical field, compliance is always a big issue. Why? Because of the surrounding side effects of antiretroviral medication. They have a very, very lot of wrong effects. But we have to encourage our patients and educate them on the need for them to do that. Patients need to be review their kidney and liver function because most of these medications are metabolized by kidney and liver. People say, well, why can't we have vaccine for HIV? Well, vaccine for HIV is not easy because of the rapid mutation. It's rapid, has so many strains, rapid, changes the form, so many forms that it is very unstable. And that because of that, the vaccine production for HIV has not been successful. Patients take prophylactic medication, something like Bactrim DS, and that medication they take to boost, making sure they don't get opportunity infections. So all of them, the other medication they take depends on specific of the infection, opportunity infection that comes with that particular patient. Immunization, yes, because the immune system is compromised, they have to get a pneumo vaccine every 5 years. They'll get a flu vaccine. Patient will get a flu vaccine every year. They need a flu vaccine every year. They get a DPT every 10 years. Patients with HIV, no live viral vaccine. They don't take a live virus vaccine because it can potentially cause an infection for people with HIV. And because of that, they don't take live vaccine. So prophylaxis is prevention of opportunity infection, which I've said something like Bactrim DS, this is from antibiotics, some of them take on a daily basis to make sure to boost their immune system and make sure they're not vulnerable to opportunity infection. Management and prevention. Well, we in the healthcare system, one of the things that happen that we don't pray, somebody can have a needle stick. If you have a needle stick here in the United States, well, you'll be tested and the patient will be tested. If it happens that if the patient has HIV or has HIV and you don't have it, well, you gotta take a prophylactic medication. The regular medication is Truvada. The patient take. You take this medication within 72 hours of exposure. However, evidence have shown and research have shown that this medication is negligible. The effect is negligible. It's inconsequent. Doesn't have any effect if it is taken 3 days after the patient is more than 3 days after patient is exposed. So it is something that I encourage my students and other things. We don't pray for it, but it happens one is exposed to that. You can get it revised if it is taken prophylactically, and that response is time dependent. It's very much time dependent. So education, we have to educate people about needle sharing program. That's not a good thing to share needle. Talk about our chemist people, because sometimes people from developed country, their goal is to maximize profit. And because of that, they don't care. They use needle for one person, use it another person. Even at this point in time, that needle is very cheap. So needle sharing can help to transmit this disease process. Because it teach them not to use an IV drug, because using IV drug shooting is also another way. Safe sex practice, the use of condom, abstinence, things we can tell people to do, whatever that works for them. But especially the use of safe sex practice is very, very important. This part of the world we don't teach about abstinence because sex is part of their life. You can't tell them to abstain from having sex. Just tell them to have a safe sex practice. It's very important. Potential complications. I've mentioned them before, but a common complication is opportunity infection, something like PCP, thermoplasmosis, the MAC, and CMV, cytomegalovirus viruses. These are very, very opportunity infection that invade the patient with HIV and cause a drastic problem. Some of them might result the patient being intubated if it's especially very pneumonia that goes in a very high place. They get intubated and they can become septic and they maybe even die from the process of that. So it's some kind of the opportunity infection. And also is the cancer. The one of them is the S-defining cancer, which is the Kaposa sarcoma, I showed you before, non-Hodgkin's lymphoma, and invasive cervical cancer. All these are S-related cancer that happen to the patient. Hodgkin disease, anal cancer, lung cancer, testicle cancer, those are some of them that are S-associated that can happen to the patient. Like I tell you, patient become malnutritioned, becomes cacatic because of malnutrition, respiratory compromise happen, and I told you in case of intubators or being in BiPAP as a result of those things to, compensate for the respiratory system. Fluid electrolyte disturbances may happen as a result of HIV, and sepsis, they may result to sepsis and might even lead to death. Dementia, you can see some of them become forgetful with time, altered mental status manifested by restlessness and irritability. See somebody that stay with them, sometimes they're irritable of the environment, the health environment, they start being pacing around and agitated and restless. And so that's early signs. Sometimes HIV, have HIV manifestation related to dementia, or we call it S dementia complex, ADC, that can happen to the patient. The continued rehabilitation, the legal implications of this CD4 here, United States recommend HIV test consent with general consent for care rather than a separate consent. Before, in most of the states in America, you have to get a separate consent for HIV testing because now they are trying to put up a law so that when you come and sign a consent for care, then you'll be tested for everything. We're still up to 14 states in the United States today are moving still with you have to have a separate consent. So I don't know about the legal Nigeria system. Testing confidential. It has to be confidential and anonymous. It's something that's so private. Has, HIPAA is very, very important. We have to protect their confidentiality because one of the things why people don't want to talk about HIV is because of the stigma, which we're going to see here. So you got to maintain their confidentiality and make sure it's not some information you share. It's a very sensitive information because it deters their persona as a person. So mandatory pre-testing counseling. It is required before you test somebody for HIV, you have to counsel them. Tell them what you're testing, tell them the implication when they become positive, tell them the process, and let them understand if there is a problem, there is hope. Not giving a false hope, but a realistic hope that is tested, empirical, realistic to the patient. And in fact, we do what is called also the mandatory post-testing. After testing, if a patient is positive, here in the United States, as a nurse, you can't just walk into the patient except you're a nurse practitioner and say, well, you have HIV. No, because the question of care is why nurses are not allowed to be the first person to discuss a diagnostic test with a patient is that if you discuss the test with a patient, now the first question the patient, well, what am I going to do? You don't know the plan of care. So that's why the providers, not practitioners, the doctors take that as a responsibility. Sometimes they have to involve a psychiatric, depending the nature of the problem, to talk to the patient about the counseling. However, here in the state of Maryland or United States, there is a mandatory name reporting to the government. That's how we keep the data. We have to report to the patient, and the patient is positive, XYZ is positive. That's within the state, is a mandatory reporting. There is also partner notification. It is also incumbent that the partner has to be notified if they have a loved one. So a call will be made to the partner, XYZ, tell them, don't tell the name of the person. Somebody you had sex with some time ago, tested positive. It's better you go and test yourself. The person has to count their teeth with their tongue. So if you have multiple partners, then you might be unable to find out who it is. But if you have a single partner, you should be able to narrow it to one person. But the essence of that is for the patient to test themselves and be able to take a trajectory of medical regimen or care that will be efficient, that is also cost-oriented and positive outcome. Nursing intervention, what do we do as nurses? As nurses, Most of our job is going to be more of teaching of family, teaching of patient, tell them about the transmission process we have talking, tell them ways of preventing, tell them about testing, medication, their interaction, what medicine you're taking, their interaction, the side effect to anticipate from those kind of medication, and let them know the importance of adherence. Compliance is the key for driving that CD4 count. So driving your viral load low is the compliance, adherence, strong adherence and compliance to medication regimen is very important. Drug holiday is not when you say, well, I take today, I'm not gonna take this one on this day because I need to enjoy my life and this. No, you have to be a complete, compliance to the medication. If there is any complementary therapy, then you have to take them together to do that. General health maintenance, support, tell them about vaccines, immunization, things that will help them to boost their body immune system, because their body at that juncture is very vulnerable to attack. Talk of other psychosocial factors, monitor for signs of depression or suicide, because it is not easy when people become decimated, when people feel that they're going to be isolated by people around them, when people going to lose some other people around them because of some other cultural things we're going to see. So it is a time we talk to the patient with all amount of humility, respect, talk to them, and then appreciate and find out from them any way you can help them. If they need a consult, let the doctor write a side consult. If they look people from with their church to visit them and talk to them, do it. Any remedy that will help them to come out from precarious, prevalent circumstances, it's going to be a very good factor to happen. So encourage patient, family, partner participation or care. Yes, sometimes here, let them know, because here is some of them are scared because of their partner. Their loved one may leave them. They may abandon them because they have HIV. Let's find out if you can have a meeting with their partner and have a meeting with them. Let the partner understand, you know what, if your beloved one is treated and the viral load is below a threshold, they are not transmissible. That might give them hope. And that's why we come as a distant, as nurses. Memory aids as posted notes, because some of them that have HIV, dementia might be forgetful. So have a memory science note on the wall to write them about their calendars, their medication they take, when they take it, at the time to take it. Explore any kind of community support. Here we have HIV group support within a community where people will go and meet people and see people. I'm not alone. I'm not the only person. I'm not the only victim. I got our friends. That help them a lot to recuperate and get themselves integrated with the fabrics of the society. So encourage patient participation or care. Involve them in their care. Involve them. The patient has to be involved. It's not something, we have to start shifting that methodology in the third world country where the doctor make decision, superimpose the ideology on the patient without the patient having a say. So the patient has to be a collaborative agent in the care we give. So the nursing intervention stay continuous. Sometimes, well, it might be depending on the stage. If they're painful, they might be into a palliative or hospice care where we know at that point in time, especially hospice, there is nothing much we can do to change the trajectory of care. At that point in time, we start talking about hospice. Find out if they have advanced directive. Do they have their CPR? Are they full code? What are we gonna do are we gonna resuscitate, do a CPR if there is anything happen? Talk about the estate plan in the wills. Start finding out at that point in time when we know there is no other things left we can do medically. We start talking about patients' will and what have. So that don't take, especially when they are cognitively intact, you can start making that kind of decision. If immediately the cognition is impaired in this part of the world, you can't make decision again for your own property, and that is very devastating. So it's good at that point in time they are very intellectually intact to start having their ways available. Patient safety, frequent reorientation, because if they're forgetful, tell them to know where you place their items within reach. If they have things in the hospital, put a table within their reach, because when it is too far away in the process of getting it, if their gait is not steady, they may fall and break their hips. Other things we do, monitor their vital signs because it gives us a clue of what is happening. Temperature let us know if the patient has infectious process that is going on. Blood pressure lets us know if the patient, are they going into sepsis? Are they hypotensive? Are they tachypnea, tachycardia? What is it at that juncture that help us to know? We monitor the CD4 count, the viral load, the weight. Dietary will come into play because some of these patients will be, their nutrition will be impaired, and we need a dietary consult that will help to supplement to something that will increase their appetite. Encourage small frequent meal. That is the kind of meal all of us should try to do. We don't want a dumping syndrome whereby you eat a heavy food, a dump in your stomach is not metabolized because the enzymes in the body need to be given a space to work. So a small frequent meal is the best way to eat. Supplement if necessary, like that will help them ensure, and etc., that will help them to supplement for their protein will be necessary. You see this man, Magic Johnson, some of you is a very great man in the source, a very well-known basketball with HIV, but he came into food that today he live a happy life. Why? Because there is a strict compliance. Strict compliance leads to a good life. The CD4 count and this viral load that were controlled. He is limited to opportunity infection, understand how to take our medication. Man, this one. So because if you are compliant with the medication, CD4 count, viral load is suppressed very well, and their CD4 count is good, then you don't have anything to fear. People with HIV, honestly, live far better life than other people that have cancer. Good life. So the most appropriate action for the nurses to take to help patients follow the anti-retrieval medication treatment regimen is for us to assess the patient's lifestyle for adherence of cue. And when you're teaching them, find out if they're going to be compliant, because that's the key. Find out from the sign. If you're teaching them, they're signing and they're taking off their eyes, they don't want to participate, that is a sign that they're not going to be compliant. So, but if they're asking the question, they're integrating and finding a question, it's saying, so look as a nurse for the clue and see how to reinforce your teaching. Special consideration here, teaching disease progression, opportunity infection is very important. Talk about immune system support, drug therapy, and when to call the provider. Aging population nowadays, we are seeing an increase in age population that have HIV. And their treatment is compounded by mobilities, stigma, and access to care. Because they have that stigma. Why am I going to tell my grandkids? Why am I going to tell my this? How are they going to know I have HIV? And then the limited access of care will also make it a problem. So what are the problems of combating HIV? One is the insufficient political will. Some political leaders don't even want to involve into this process and bring the resources that help to combat this thing. The frail health, our healthcare system, most part of the world are frail and fragile, that we don't even have a sufficient fund to do that. There is a weak support from the community-based organizations, who is not supposed to do. We're supposed to have a non-profit organization that will help to pump resources and help you nurses and all of us to go and start preaching this mission and help these people that are not, so that they don't, they have some hope. The cultural taboo and social stigma is also key. In some cultures, if somebody dies, even if they know HIV, they don't even want to touch the body, not to think of, you have to go and hire somebody. Knowing fully well, all you have to wear is your glove. You don't get HIV by touching that person. So that social stigma demarcates people with HIV, and that's why most of them don't want to get involved or make it known to the people. The insecurity in some places, well, even if you have fun, are you going to go to Imo State where they will cut your head with unknown gunmen? So that's kind of become a very problem. Humanitarian crisis continue to threaten and revise the progress. And the last slide I will do, because I know I was giving 1 hour, and I will limit it to that 1 hour. I love to talk. That's how I make my money, but I will limit it to that 1 hour. The HIV of healthcare workers in combating, the role of healthcare workers in combating HIV, all of us. Number one, we have to care of pregnant women, test them and find out if they have HIV, breastfeeding mother to prevent the transmission of HIV, if they do, from mother to child. If they do, they need a medication in order to deliver a comprehensive care to people living with HIV and their family. At times, and location that are convenient to them. You find a location that's convenient and give it. You don't come to a marketplace or an open place. Oh, these are HIV people, I'm gonna treat them. No, it needs some privacy for them to open up to you, for them to communicate, for more people even to come on fold, if you can provide that privacy. Support key population, including men who have sex with men, homosexual, heterosexual, gay people, other people, because in the United States, the greatest number of people that have HIV is men to men, people that have to men, homosexuals. So encourage them, prisoners, those are people that have that are homosexual and other things. So encourage them, integrate them. Don't be judgmental because of people's either color or because of sexual preference. That is for them and their God. That's not your role as a healthcare provider. Your role is to provide a care that is impeccable, unadulterated, unfettered to these people to maximize their life. Promote efficient testing in community, facilitates hotspot so people know their status and can initiate treatment as early as possible. Decentralize HIV service to communities and low-tier health settings so more people in more places, especially adolescent men and those left follow who have access to service. Good to have access to care is the key. And integrate HIV services with other sexual and reproductive health intervention, recognizing the opportunity to meet people's needs in a single visit. So if somebody have HIV, well, put it care when they're coming for their blood pressure check, their daily check, hypertension. Don't say today is just for HIV. No, incorporate it to be part of care the patient is going. Challenge restrictive policies and inspire government to uphold the rights of people living with HIV, especially key populations, adolescents and women. Some other people say, well, majority of people are homosexual, they're the cause of the problem. That is not our goal. Nursing is a holistic, compassionate, caring, empathic profession that we give with impeccable at all points in times to people that deserve that care. On this note, let me use this opportunity. I have a video here that I want to, because I don't have much time for you to play, and it summarizes everything I said on this particular topic, but you can play it on your own. Just to know, it summarized, that video summarized everything that I said. Before I drop, let me use this opportunity to thank Busaya for your wonderful coordination you're doing. You know, sometimes it's difficult for me to respond to this thing, but I saw her persistence. You are sending me this, and I had no choice. And Dr. Kintere has been my mentor. He when he was here at University of Maryland, he's a mentor I never had. He made my transition seamless, and is a man I cannot say no. He stands tall. His name stands tall in medical profession in the United States. And without further ado, I thank all of you. God bless.
Wow, thank you so much.
Thank you so much.
Thank you very much, sir.
Thank you, all of you.
Thank you so
Thank
much.
you, Dr. Anthony.
Thank you, all of you.
Yes, we definitely learned a lot. Even me as a nurse, I'm definitely going to take a lot of, the things I've learned today into practice.
Thank you.
You're welcome. So I don't know,
Thank
just
you.
before we go, does anyone have questions? I have questions.
Yes,
But
please.
does anyone have questions? I'll ask my questions and then
Please, Nancy, speak up and ask question, please.
Yes. So I have a question. So you talked about the importance of, policy with, HIV, reducing the prevalence, reducing the spread, especially in Nigeria. So what are some of the ways that we can advocate for policies? Because lack of political will is one of the main issues with our healthcare system. So, what do you think is one of the ways that we can promote?
Excellent, sir. Thank you. Well, thank you. My major in my master program, my major policy is policy writing and policy advocate. I've been involved with an American Nursing Organization in some policy drafting and some other stuff. So what happened is that our country is a country that is very resistant to change.
Yeah.
It is a country where we have a predominant people at the heads of their faith don't even know the importance of what we're doing. But what we've capitalized is that there is what we call in leadership window of opportunity. You look for opportunity. When I wrote a program in a particular hospital about reducing the use of physical restraint, well, I waited until the state came. They made a mistake and the state came to close the hospital. At that point in time, they needed it most. they had no choice. And I told them, you know what, this is what I have in point. So now you capitalize on the point when you know if you know where the rate is high and people are dying, and you know people like the councillors and people at the corridor of power, you start having this organization presentation within people, communicating the idea, because you must have a buy-in. It is not easy to change the status quo because they have already, some of them are dogmatic. They have already built their own ideology. So for you to uproot it takes time, but you start small things, especially when you know their beloved one has been affected. That's when you capitalize on that and start having a small presentation. You know, HIV, what is HIV? How do you protect it? Do you know that people that have HIV can live a good life? So you start driving point in them. Immediately you get one or two of them that have you to portray your idea. That's a way to start it. That's one. Two, also start writing. Article publication that I saw that people have a newsletter. I might even write something about HIV and post it there, and you communicate it to people. People start reading because the taste of a pudding is in the eating. You gotta eat a pudding. If it doesn't affect you, you don't know how it tastes. Somebody said, how do you know when you have not tested it? You know, if my patients of those days, I took them to a clinical setting. The patient said they have a cancer. My patient went there, said, I know how you feel. The patient slapped my students. I said, do you have a cancer? She said, no. She slapped the patient. How do you know how I feel when you don't have cancer? And that's true. But I mean, she went to the other side. You don't know how these people feel because you have never been in that place. But we try to imagine the precarious prevailing position they are in. And that's the best single way you can start doing. So start writing small article, start having some organization, start talking within the church system, the church where we are, because right now our people believe so much in God, which is helping them. So go through that with their belief and see what you can do to achieve results.
Wow. Thank you so much, sir.
No problem. No problem.
We'll
No problem.
definitely pick you up on writing a piece, you know, on our newsletter.
That's fine. That's fine. That's good. That's good. Yes, just let me know. Give me a small time. Tell me, I'll put something up for you. And for those of you, if you're in Nigeria and you one of the opportunities people in third world country have is that taking NCLEX. Nigeria, America is the land of opportunity. I mean, it's a land of opportunity. You can always tap on it. So if you're there, you try to take NCLEX. My organization, I'll give a review on the NCLEX for 2 weeks, and you'll be able to take it and pass it. But doing is well tested. So as you do that, Hussein knows my contact. You can always contact. I can equally come here one day if I have time, give a brief lecture on paid. Sometimes I pay a lot of money for you people just because of Dr. Kintede. There is anything I cannot do for him, I will do it for him. And I tell people, and without further ado, I have to tell people talk of ethnic division. No, your best, you can get the best friend from somebody. I met so many people from Igbo land here. They were not as helpful as Dr. Kintede. He took me as a brother. He brought me in. He fought for me. At the time, it was precarious. So that's the kind of individuals we need. And my own, I'm open to every person. I thought in Lagos State, I'm a Lagosian by nature, and I'm part of it. So feel free anytime you call me at my service, you get it.
Thank you so much, sir.
Okay. Any other question?
Any questions?
Good day, Professor Anthony.
Good day. How are you, Adiola?
Good. It was a wonderful presentation. I'm really amazed that you cover a lot of ground within the short space of time.
Thank you so much.
My question is closely related to what Busayo has to as regards policy and that. Because our program is mostly focused on preventive healthcare aspects at the community level. So the question is, there has always been this issue of stigmatization, particularly at the community level. We've talked about the newsletter, the other avenues through which we can help to bust misconceptions and myths concerning HIV. There are this community level, a lot of people they might not really understand it at that level. So I don't know what we can do differently in order to reduce stigmatization, because HIV has really been around a long time. And when you communicate with people at the community level, you still find out that a lot of them still have certain misconceptions you don't expect to still be thriving. So what can we do differently at the community level, particularly
Excellent,
among
excellent.
adolescents?
Excellent, excellent. Honestly, the nature how HIV, thank you so much, Adela, for your question. The problem of stigmatization is a very big problem HIV has. Look at COVID. COVID doesn't have any stigmatization. People are free to say I had COVID. People are very free to say, even when COVID is more deadly as HIV. But the problem is the way it started. And people came, and not only the way it started, it perused into people's style of life, which is sex. It integrated with sex. And sex is part of life. If you want to have a child, you got to have sex. You got to get married. And people think, okay, if somebody have HIV, why am I going to marry somebody with HIV? Some other people in villages think that if somebody has HIV, well, everybody in that country, in that village, they must have HIV. So like I said before, always the illiteracy is part of the problem holding us behind. One of the ways you can start doing that is like the Magic Johnson I showed you. Think of other eminent Americans. Here, people take pride to say, you know what, I'm a gay, I'm lesbian, I have HIV, but it's not because of our social stratification in Nigeria, it is a problem. So all we have to start is print the newsletter of all these highly profile individual millionaires and be sharing it in the church and give a lecture. Remember, this man has HIV. He made mention of that, has so much money in the world. Today, his HIV is already, the CD4 count is less 50. He can have unprotected sex with the wife. The wife doesn't even have HIV, and this haven't. So it's something that's going to take our time, but we have to start from the grassroots. Let them know that this has happened to people that are very successful, millionaires, rich people, and tell them to know that if this hope, if people go into this process, it's going to help you to do that. It's not something we can do. One day you do that, involve their community leaders into this group. I'll talk to Dr. Kinton. I don't know how much you do. If they have some grants that people can reach to the communities, talk to them, bring them on phone and start talking to them. Bring antiviral medication free and begin to them. Create an environment that's conducive for those people and start giving them medication free. The medication for antiviral is not like medical mission, where you give medication this month, you will give another. I'm not a proponent of medical mission because medical mission doesn't do any problem. You go and give people medication for 1 month and you're gone. And they don't have any medication for the rest of their life. That's not a problem. What you're doing is good. Prevention, screening. Focus on that. Encourage more people to start testing themselves. Give the kits, give it to them to go and test themselves at home. Teach them how to do that. And start finding, see, you know what, if you have it, there is hope. Most people don't know there is hope for HIV. And that is why they're still hiding. If they know there is hope, that he can suppress it, they can live a normal life. Their fear is sex. If they know it, nobody will come out of contact with them again. Their wife will run away. Their beloved one will run away. So I bet they better live with it and die with it. So, but just is a kind of, trying to bring out that kind of psychological belief by bringing a lot of education. So it's more of education and teaching. That's the point I'm going to say, Adiola, into that.
Okay, thank you very much, sir.
Thank you. Thank you. Thank you. Thank you. Any other question? Because I don't want to take your time for your workshop. I know you all have so many other things you will do. If you don't have, thank you so much for giving me this opportunity. I look forward to seeing you people sometime again. Okay?
All right. Thank you so much, Dr. Anthony, once again. We do appreciate you because, the notice was short, I think, but, you see honor us and come here today. We appreciate that. Thank you so much.
No problem. No problem.
On
Thank
behalf
you so
of
much.
Prof and the entire team, we say thank you.
Thank you so much. Thank you, all of you. Thank you, everybody. You all have a nice one, okay? I wish all of you the best.
All right. Thank you, sir.
Thank you so much, sir.